Good morning. Welcome to the 7th annual Philip H. Gordon Visiting Professor Lectureship. As many of you know, Dr. Gordon was the first director of colorectal surgery at the Jewish and at McGill, and he was the first fully trained colorectal surgeon in Canada who devoted his practice solely to colorectal surgery. He was an icon in the field, having been the first president of the Canadian Society of Colon and Rectal Surgeons, which he founded, and the first non-American who was the first non-American president of the American Society of Colon and Rectal Surgeons. He authored numerous peer-reviewed papers and authored several editions of his textbook, which serve as the reference book for colorectal surgeons across the world. In honor of his marked contributions locally, nationally, and internationally, we set up this lectureship years ago in order to honor him. He would be very happy with our guest speaker today, Dr. George Chang, who comes to us from MD Anderson in Texas, where he is the professor of colon and rectal surgery and associate vice president of regional surgery strategy. He is he has the Sue and Radcliffe Killam Chair and is adjunct professor of health services research. He has extensive expertise in minimally invasive robotic surgery for recurrent and advanced rectal cancer. He has research focused in clinical comparative effectiveness for cancer treatment and care delivery, which has formed part of the guidelines for cancer treatment and guidelines for national surgical quality standards. He holds the NCI NCORP Cancer Care Delivery Research Program of the Alliance of Clinical Trials in Oncology, and he has been a member of the JCC Steering Committee of the National Cancer Institute, the Commission on Cancer, and is currently the co-chair of the AJCC Lower GI Panel. He has peer-reviewed 300 manuscripts, edited a rectal cancer textbook, and serves on numerous editorial boards in many journals. He is an excellent speaker, and this morning he's going to talk to us on early onset colorectal cancer, which is an issue that's plaguing us as colorectal surgeons as we see numerous younger and younger patients who present to our office with cancer and no symptoms prior and in an advanced stage. He's going to, and we cannot also pick up a media report, whether it be Time Magazine, the New York Times, or peer-reviewed journals, which highlight that this is a global phenomenon. He's going to give us a talk on early onset cancer and elucidate what's going on, because we really don't understand it. So without further ado, Dr. Chang.
Thank you, Dr. Vasilevsky, and for that very kind introduction, and for all of you for joining us today. It's been an amazing 2 days. The hospitality has been tremendous. We had a wonderful evening last night. I'm very proud to sport my McGill tie today as a result. In my pocket, I've got my McGill pen. So I am all ready. And of course, I have to congratulate the finishing fellows who have reached an incredible milestone in their careers, finishing the fellowship here. These are my disclosures. And I wanted to take a moment and Dr. Vasilevsky's already, described Dr. Gordon's tremendous contributions. And, it is 2025. So I went to Copilot and I put in his name, and this is what I got. And it pretty much summarizes it all. A pioneer in colorectal surgery, leadership roles, founding president of the Canadian Society for Colorectal Surgeons, his numerous academic contributions, his awards and recognition, and his advocacy for patients. I'm just going to make this so that I can put the pictures of everyone off. And then, and anyway, it even talks about the annual lectureship in his honor. So, really, really, it's an honor to be here. I had the privilege of being here 10 years ago during the 40th anniversary celebration of the Colorectal Society, and at that time had the opportunity to interact with Dr. Gordon, and he's just a remarkable man. So it's a true honor to be here to be the Philip H. Gordon Visiting Professor. So I think we should start with some good news, and that is that colorectal cancer incidence and mortality is declining. Actually, even we would think that's not the case, but it's actually declining. And you can see this is data from the US. Overall incidence, or male or female, however we want to look at it. We have the incidence up in the upper lines. Let's see if this works. Yeah, can you see? Okay, great. And then we have mortality, and we can see mortality actually has been on the decline as well. Incidence, of course, is number of cases, newly diagnosed cases per 100,000 population. Now, the total newly diagnosed cases in the US has actually leveled. It actually is not declining because the population is growing. So we still have 150,000 newly diagnosed colon and rectal cancer cases every year. In fact, it had been declining a little bit. Maybe now it will decline as the population decreases some more. But anyway, on the right is data from the Canadian cancer statistics. And it excludes Quebec, but includes the rest of Canada. But what I point to, in fact, this is from the monograph. Colorectal cancer incidence is declining faster than any other cancer in Canada. And that is a testimony to the success of the efforts of the entire community in bringing awareness, promoting screening, and treating patients. And you can see that minus 4% per year in men and minus 3.1% per year in women. So then why do we have these headlines? And we just heard a lot about them. And, we've been seeing these headlines for years. And I remember I was in Adelaide about 10 years ago at the Society of Surgical Research in Australia. And we had published a paper. And so I was doing an interview with Ira Stein. The only time ever that I've interviewed with, he's one of the NPR health correspondents. And we were talking about the rising incidence of young onset colorectal cancer. And that was 10 years ago. But it is something that, continues. I think back then it was not as widely appreciated in the lay press, et cetera, as it is today. And we continue to hear about it today. And in fact, on the right, you can see actually Canadian, news. And I think this is a internist from Vancouver who's being interviewed by the CBC. It says Vancouver there. So, but clearly it is a really important problem that has got a lot of attention, which is I think really good because it highlights the issue. So if we were to dive in just a little bit further, this is more incidence data, but colorectal cancer still remains a disease of older people, right? Disease of people over the age of 50. I can't say older people about people over 50 anymore. So of young people over 50. But the majority, in fact, almost 90%, 87%, 86 and change percent of diagnoses will be made in people who are over the age of 50. And in fact, that they have driven the improvements in that we were just sharing. If we look at all the age cohorts, 55, these are by every 5 years, 55 to 60, and so on, we can see that whether it's colon cancer or rectal cancer, the incidence has been declining. Why? Well, probably because of successful screening. But when we look at the younger cohorts, we can see there's been a dramatic rise. And in fact, especially in the youngest, 20 to 29, we have a much steeper increase in the of the slope of the incidence rates. And this actually persists, and actually it's quite notable that recently we've had a little bit of an uptick between 50 and 55 as well. And actually there's also been a little bit of a shift in where those cancers get diagnosed. In other words, moving leftward in the colon. So we're seeing a little bit more of that younger phenomenon. And I think that might actually help us to put into perspective some of what we're learning about young onset colorectal cancer and understand better kind of the potential environmental impact that actually is resulting in this. But rectal cancer is much more dramatic in terms of the increasing incidence, where in young people, we're especially seeing a rise in rectal cancer. This is some work, and in fact, this is the work I was talking about before that we were discussing with Ara Stein for NPR. And we had looked at data from the Surveillance Epidemiology and End Results Registry in the US. And we looked at patients in different age cohorts with different stage of disease. And what you're looking at is colon cancer on the left and rectal cancer on the right. And the oldest being up at the highest line and so forth, and the youngest at the bottom. But what you can see is exactly what we were looking at, a declining rate of cancer in the older population and an increasing, and dramatically so, rate of cancer in the younger population. And so we took this data and we modeled it, and we modeled the changing incidence. And pictures can be quite traumatic. And so when we start to model relative amounts, we could see actually pretty dramatic increases. Still relatively small in absolute terms. We saw that the vast majority are still being diagnosed in older people. But we predicted actually, based on the historical trends, if the trends were to continue, that is both the rise in the younger population and the decline in the older population, we would have, so based on the trends in the younger population, we would double the rate of colon cancer and more than double the rate of rectal cancer in the youngest population by 2030. And we would go from 5% of colon cancers being diagnosed in people under 50 to 11%, so 1 in 9, and almost 1 in 4 rectal cancers being diagnosed in people under the age of 50. I mean, really, really dramatic numbers. We have yet to sort of go back and validate our models now that we have another 10 years worth of data, but it'll be something interesting for us to do. And what that has resulted in actually is a decline in the median age at diagnosis. So, historically 72 very consistently was the median age of diagnosis of colon cancer. And now we see that the median age is 66. And so, again, reflecting the growing incidence in the young population and improvements in the older population. This has also been described and characterized as a birth cohort effect. So if we look at what decade were you born, what is the sort of the anticipated rate of colon or rectal cancer development. And you can see here that whether we look at it by sort of your age or the year of birth, there was an inflection point right around 1950 in terms of your birth year. And you can see that rectal cancer has a much steeper rise. And we're seeing, and this is consistent with the data that I just shared. It's not unique to the US. This is data from Cancer Care Ontario. Exactly the same phenomenon of, this is the incidence, the age standardized rate of colon and rectal cancer for the population between 30 and 49. And you can see a dramatic rise. So this is happening here. It's not a North American phenomenon. It's actually happening all over the world, particularly in more developed countries. We're seeing it more. And these are mostly Western countries, or Europe and Canada, the UK, Scandinavia, New Zealand, but we're also seeing this in Asian countries as well, but pretty dramatic. Look at this change. 18% in Denmark. Now, some of this is probably diagnosis, right? There's been a lot more awareness. People are going to get screened. But the amount of screening that's actually being done, or the amount of sort of colonoscopy and testing that's being done, is far too small to explain this dramatic change. So pretty remarkable. I'm not sure what's going on in New Zealand, actually here in Canada too. I think the numbers get small, or it's just missing Quebec. Maybe that's part of the problem. And then we see, actually, this is sort of a heat map by country. Around the world, you can see the age standardized rates, and Korea 10, which is comparable to Canada and the US. The other problem, in addition to the rising incidence, is that the mortality is also on the rise. And we can see that essentially since about 2005, it kind of leveled off between 1990 and 2005. It was fairly flat, but we could consider, if we did a joint point analysis here, probably it might pick out 1995 or close to 2000 as being that inflection point. But clearly there is there's an increasing mortality, whereas in the older population, we still have a decline. Now, this is kind of remarkable. I think this is a really interesting phenomenon. We're going to have to look into this a little bit more, but we're seeing kind of a leveling off in that 50 to 65-year group. And along with that, we're seeing a shift in the location of tumor. So kind of an interesting phenomenon, but particularly in the older population, the earlier birth cohorts, dramatic improvements. In men in 1980, it was 200 per 100,000, the mortality, and today it's less than 100, like it's less than half. That's pretty dramatic. There are some other things that go along with this rising mortality. The younger patients have more advanced disease at presentation, and here is some data. This is work that our group did and with Nancy Yu. The gray bars represent the more advanced stage. And so when you look at young onset colon and young onset rectum versus later onset colon and later onset rectum, significantly higher rates of stage 3 and stage 4 disease. And this is borne out in updated SEER data. We can see that amongst the young population, 20 to 49, red represents regional, black is localized, blue is distant. So very high rates of regional disease and also high rates of distant disease. And look at the separation that we have in the older population. We're catching cancers earlier in the older population, but it is still rising in the younger population. So what's causing all of this? I think that's kind of the big question. And the spoiler is, I don't know. But there's a lot of really interesting data that maybe we can go through. So one thing is that, young onset colorectal cancer, isn't that all hereditary, right? Isn't it all due to hereditary or some familial risk? Well, about 15 to 25% of patients who are young at diagnosis, so under 50, will have a pathogenic germline variant. So this is some data from, I think this is from I think this is from N1047, which was an adjuvant therapy trial in colon cancer. And this is data from MD Anderson. So 20% of our patients who are young have a pathogenic germline mutation. Now, if you go to the younger cohort, so if you go like 20 to 35, it's 25%. It's higher. And if you go to between 35 and 50, it's a lower. It's like 16%. But still, the vast majority are sporadic. And so why is that happening? We also know that it is more distal. So this is actually data analysis that was done primarily at Memorial Sloan Kettering, looking at tumor location. So you've got the youngest, 14 to 35, the sort of the middle group, which is 36 to 49, and then the average age, which is 50 and older. And you can see that there is a tremendous leftward shift. Interestingly, there is a bit more right-sided disease in the very young. because the very young are more likely to have a hereditary syndrome. And so with Lynch in particular, we're seeing that more on the right side. So that's kind of an interesting phenomenon. We also see differences in the carcinogenic pathways. So on the, if we have microsatellite stable tumor, we have very very low rates of BRAF mutant on right-sided tumors. On left-sided tumors that are microsatellite stable, we have we don't have chromosomal instability. We have low rates of CGP island promoter methylation. Again, we have low rates of BRAF mutation. It's very different. We have high rates of CGP methylation on right-sided tumors and average age at onset, and we have high rates of BRAF mutation. You can see that here on the right. This is a different study using data from multiple institutions, but we can see here in the light gray bars are SIMP high tumors. And so this is later onset MSI high, early onset MSI high, and completely different, like completely reversed carcinogenic pathways, right? KRAS mutated pathways here in the dark gray, very high rates in the young versus in the later age and onset. And then when you have those that are microsatellite stable, they have a high rate of KRAS mutation all around. So there are clear trends, and there are trends from the location within the colon as well that are apparent in the average age at onset or older age at onset that don't exist, at least in a statistically significant way, in young age at onset. So clearly there are some differences in the way that cancers are developing, which makes sense because the duration of time it takes for the polyp to become a cancer or whatever precursor must be accelerated, right? If we're getting cancer at 25 and we classically think of it as a 10-year process to go from polyp to cancer, it's happening at a more compressed time scale. There are also some there's been a lot of interest in looking at molecular alterations, and there are some unique molecular alterations in young onset colorectal cancer. So we see all classically the APC, the TP53, the KRAS mutations, et cetera, but we're also seeing higher rates of MSH2 and 6 and BRCA mutations and SMAD4 mutations, a lot of mutations that kind of localize with the Wnt signaling pathway. We have higher rates of tumor mutation burden, and obviously more MSI tumors. And this is some additional work that was done, led by Scott Kopetz at MD Anderson, looking at the different CMS subtypes of tumors. And what you're seeing on the x-axis are decades of age. So sorry, it's pretty small, but it's like it goes 30, 40, 50, 60, et cetera. So in the very, very young, we have high rates of CMS1. And then we get that again in the very old, but in the middle, there are lower rates of CMS1. And so these may all have implications for our therapeutic strategies, not just the therapeutic strategies and the targeted strategies we have today, but in potential strategies that will be developed in the future. The other sort of very exciting sort of new information about this is the impact of gut dysbiosis, right? We know the microbiome is extremely important for carcinogenesis, and we know that the bacteria in the gut can create toxins, and these toxins then can cause inflammation, cause breakdown of our mucosal barriers, and the three most notable. The three, I don't think I have anus on here anywhere. The three most notable Bacteroides fragilis, Fusobacterium nucleatum, and E. coli that creates a toxin called colobactin. And this actually has gotten a ton of press recently. And then these environmental factors that interact with the bacteria to promote or to potentially, potentiate the effects of some of the toxins. And so all of these things, our diet, our antibiotic exposure alters our gut microbiome. And so this was just published in Nature last month or April or May and got a lot of press, but looking at early exposure to this colibactin, which is a mutagenic toxin that's produced by certain strains of E. coli. And it is associated with more distal tumors, and it's associated with young onset colorectal cancer. Perhaps there's a clue here as to why we're seeing more distal tumors now and a rise in people who are in that 50 to 55-year range, because their lifestyles probably are a lot more like people who are 35 to 40 in terms of dietary and environmental exposures today, right? So, and as we, as the population lives longer or gets healthier, et cetera, right? Back 100 years ago, 55, you were lucky to be alive. And so, and as we see that shift in the population, we may be seeing some of these phenomenons if truly it was all driven by these kind of environmental exposures. This is the sort of Colobactin signature. And we can see that based on age and onset, there are differences in the positivity rates of this signature, and also based on tumor location as well. So really interesting findings. There are obviously been a lot of studies that have looked at, and this is actually Canadian, looking at this was actually a systematic review that was done by the group in Calgary, and looking at different sort of epidemiologic factors. And we always think about, male sex and Caucasian ethnicity. In fact, now I don't show the data, but we always in the US had a much higher incidence rate amongst African Americans. Now Caucasians have caught up. It's interesting because incidence rate hasn't been rising at the same rate amongst African Americans. It's just that Caucasians have caught up. And then family history, of course, is the most important sort of risk factor. Alcohol consumption, there's a lot of controversy about that. And then smoking, of course, and I think we're starting to see we have much lower rates of smoking. The exposure rates are much lower. So that data is starting to get a little bit muddier as well. And then other factors, hyperlipidemia, sedentary lifestyle or sedentary occupation. A lot of these factors kind of go together. If you're a bus driver and you're kind of sedentary, you're also getting heavier. And so, and probably not eating that well. And all of these things kind of go together. Really interesting data that we saw at ASCO this year. About inflammatory diets and survival outcomes based on secondary analyses of clinical trials data from CLGB 8642, 724, whatever it was, but the celecoxib trial. And really interesting because lower inflammatory, so individuals who tended to have a lower inflammatory diet, lots of good fresh fruits and vegetables, not as much bologna and hot dogs and things, had better survival, and they were all treated the same. So really interesting. And I think we're seeing kind of the same kind of effects. So there was a Canadian study. Actually, the Canadians are so good at doing these kinds of large studies. Ontario Health Study and Alberta's Tomorrow project with 130,000 participants. Actually 270,000, but 130 were less than 50. And amongst those, only 98 cancers, colorectal cancers, which if you do the math is pretty low, actually. But strong association with family history has a ratio of 2.8. Strong association with smoking has a ratio of 1.9. Kind of a borderline association with daily or weekly alcohol. It didn't reach the sample size is small here, so I think that may be part of it. But probably the effect is a much smaller effect. It wasn't associated with sex, income, education, obesity, diabetes, hypertension, physical activity, diet, etc. But again, it could have been a sample size issue. But I think we're kind of seeing the same themes. But I put this up there just to say, there's a lot of lack of clarity in the data. I mean, we have a lot of supportive data for everything we have supportive data for. There is probably another study that says maybe not as much. But I think there is a lot of sort of, it stands to reason. It's a lot of sort of face validity with some of the observations that I've made. So now that we kind of have talked about kind of the rise, sort of the epidemic, if we want to call it, what we understand about, how it has come to be. Now we've got patients in front of us. And, how do we manage them and how do we best treat them? Our younger onset patients have a lot of sort of distinct requirements, I think, for their management. Like for us to really treat them in a patient and human-centered way, I think we need to also recognize the unique challenges that they face. And it goes from diagnosis to treatment to survivorship and to both primary and secondary prevention. What are some of the things? Like if you're, I have patients who are in their 60s and I feel like it's their career because they've retired to go to the doctor. Like, they're like, I'm like, well, let's try to bundle your, oh, it's okay. I don't have anything else to do. I'm like, oh, I do. And a lot of young people don't have primary care specialists. So now they've got some unusual symptoms and like, well, I don't have a doctor and they can't get one. And the next appointment's like 2 months later. So these are things that are major challenges. Hereditary cancers affect young people more. We have to think about reproductive health. If we have rectal cancer, there's radiation. We have to think about, and chemotherapy, obviously, is at least, at the time, mutagenic. And so, we have to think about reproductive health and ensure that, we understand what our patients' goals are. Employment, a lot of interest in looking at workplace accommodation as one of the key indicators of risk for financial hardship, right? Because if your employer says, oh, go take care of yourself, Mr. Smith, versus the other one says, well, you know what, if you don't come to work, there might not be a job for you tomorrow, right? I mean, I think these are all super big challenges and that affect, people who are employed, and they're employed at an age where it's so critical to be employed because they have young children and they have older adults, and they also have to get to soccer practice. And so much more complex care needs. They have more financial constraints. They don't have a nest egg. They don't have savings that they can tap into like our older patients do. And we also know there's a big wealth gap amongst older people and younger people today. And then, of course, colorectal cancer is likely to be cured. And whatever we do to them is going to impact them for many, many more years than someone who gets diagnosed, at a later age. So really important to be thinking about a lot of those things. And, this is a survey that was done. It was sort of a convenient sampling. So we take it for what it's worth, but from the Colorectal Cancer Alliance, which is a, big patient advocacy group, and surveyed 884 patients who with colorectal cancer about, what their presenting symptoms were, et cetera. And blood in the stool was the number one. And that makes sense because it tends to be more left-sided. So we get more blood in the stool, but, it kind of runs the gamut. But these are all kind of relatively late symptoms, right? By the time we see blood in our stool, that's a relatively late symptom. How long did you experience symptoms before going to the doctor? You can see that, almost a quarter of the patients waited more than 12 months. Some waited even more than 24 months. But, the vast majority waited at least 3, if not 6 months. Almost half of them waited 6 months. So we're already introducing a delay. And then once they go to see the doctor, how long did it take you to be diagnosed with colorectal cancer after you first sought medical care? Well, the good news is a lot of them got diagnosed fairly quickly, 1 month, but you see that there's still patients, 20% that took more than 12 months, 25% that took, more than 6 months. So that's a long time because somebody said, oh, it's hemorrhoids or, and in fact, I think this is really telling. 75% of patients said they saw at least 2 different doctors to get to the diagnosis. And in fact, almost 40% had to see at least 3. Some even had to see at least 4 doctors to get to the diagnosis. And, I don't know if this means they saw their primary, which they didn't have probably, and then a gastroenterologist. But either way, not being able to get to that diagnosis right away is a challenge. Now, this is a study that was at Stanford by Uri Lauterbaum and his group, but looking at young onset, and so you can see less than 50 and less than 50, non-advanced and advanced stage, kind of trying to understand why are we seeing more advanced stage? And you can see the overall duration of workup was shorter for the patients with advanced stage disease. So clearly it's not just the delay of diagnosis. There is something else that's going on. Maybe there is an intrinsic delay to even get to go find a doctor. So that couldn't be accounted for in this study. But the symptom and workup periods were actually shorter for patients with advanced cancer. And you can see the rates of hereditary disease, 7% overall versus 1% overall in the older patients, and the tumor location being more distal colon, et cetera. And then 70% being more advanced stage versus 63%, that was significant. So These are what we've been talking about, all along so far, but very, very consistent in the data. More left-sided, more advanced, more hereditary, and presenting with more advanced stage disease. So now another sort of important thing we have to think about and we just talked about 7% hereditary. We need to think about hereditary risk and genetic testing. And in fact, genetic testing is a really important thing because it impacts not only the patient once they become a survivor, kind of our treatment strategy nowadays in particular, also all of their relatives. And so this is a study that was led by Marie Wood, who's a medical oncologist with interest in prevention, and looking at looking at practices that participate in the ASCO Practice Quality Initiative and the rate of genetic testing that ultimately got done on patients who presented with early age or present breast or colorectal cancer, and identified those patients who had risk criteria that should have led to genetic testing. And what we see in colorectal cancer is that only 26% of the patients who should have gone to genetic testing and who should have been referred to a genetic counselor and then subsequently got tested, we know there'll be another drop off there, only 26% actually got referred. So this indicating that, we need more awareness amongst providers and we need a better mechanism to be able to communicate with our patients, about the importance of that. What about, another important issue, which is fertility? So now we're seeing all the gaps that we have in care. Only 31% of the patients in that colorectal cancer aligned survey reported fertility preservation was discussed. And so this is, this is an important topic that we should be thinking about with our young onset patients. Financial hardship. Now this is, tremendous amounts of financial hardship. So as expected, 3/4 of the patients started off employed. But if you look over here, you can see that this represents the dark blue, not the teal, but the dark blue is that you either took a leave of absence or you quit your job or you quit school or whatever it is in order to manage your cancer. And you can see that 2/3 of the patients had to do that. In fact, Christine Veenstra, as a medical oncologist at University of Michigan, had done a study looking at bankruptcy rates or financial distress rates amongst stage 3 colon cancer patients getting adjuvant chemotherapy, and it was a huge rate. It was like 50% or 60% of patients, having financial distress because of adjuvant chemotherapy. And so and a lot of it related to time off of work, et cetera. So, and then here's sort of the survey respondents. I feel financially stressed, always 1/3 of the respondents, because there's less buffer. They have less savings, they have less reserve, and more than half the patients feeling at least often. And then, this is US data, and I don't know what it would look like in Canada, but a lot of people, like 3/4 of people, feeling inadequately insured, right? That they don't have adequate insurance to manage their disease. So this is sort of a conceptual diagram of thinking about all of these different components. Fatigue and stress, financial strain puts on more stress, makes us more tired. Out-of-pocket treatment costs, are high, particularly for our younger patients, our younger population that often is underinsured. Their deductibles are higher. Lack of knowledge and experiential learning about how you interact with the healthcare system because this is the first time you've been sick. And disruption of your regular developmental transition, because in order to get to be that senior person who has that nest egg, you have to be promoted in your job. But if you have to take a diversion to get cancer treatment, you now have missed your opportunity for that promotion or to get the advanced degree, et cetera. And you don't have that reserve. And so there's a tremendous impact of all of these things. And that is what contributes, to that financial toxicity and a high rate of bankruptcy as well. And so much bigger problem in our young onset patients. And then it's not just our patients, it's their caregivers as well. So this was a survey of caregivers of patients with colorectal cancer. And if you're 70 and your primary caregiver is also close to 70 and also retired, they also have nothing to do other than to come to the appointment. But if you're young, then, they have to take time off of work to come with you or and they, in the meantime, they're also often taking care of children, et cetera. So that's another major issue. So it's sort of a double hit. And then, we're looking at the age of the caregivers here. And so I think we're starting to see parents coming into play, becoming caregivers. And, but still 75% of the caregivers are under 50, 60% have children under 18, so that are dependent upon them. And then of course there's a strain on the partnership because 26% experience loss of intimacy, almost half have a strained or have ended their relationship. That's another major stressor on top of the cancer treatment. And then, of course, on top of that is the financial distress. So it's like piling on the stressors that our young patients are experiencing. And so we see this here. And this is data from about 830 patients at MD Anderson comparing young onset versus average age onset. And we can see significant differences in levels of anxiety. Sorry, the asterisk got covered, but levels of anxiety, and then, of course, body image and sexual function in young patients significantly worse than in the later age at onset survivors. The ostomy, how could we have these conversations when I talk about ostomy? And it also has a tremendous impact, both in terms of, so we get a lot of support from social engagement, but if we now don't have social engagement because we have difficulty managing our ostomy, then it only adds to the challenges. And here you can see that 3/4, actually 80%, 4 in 5, experience at least sometimes some social interaction difficulties related to the stoma. And then, of course, sexual dysfunction, is tremendously impacted as well. So now it sounds very depressing. How do we work to improve the outcomes? Well, first is we make the diagnosis earlier, and we, try to actually identify people at not only a treatable age, but also prevent cancers if we can identify the precursor lesions. So a little over 5 years, I think it's 2018, the U.S. Preventative Task Force lowered the screening age in response to all of the literature and all the discourse that was now coming up in the evidence. And of course, you could screen younger. It's always about society's ability to pay, the potential toxicity, et cetera. But so screening age is now 45. We can try to raise awareness about the importance of thinking about all the relevant issues, including genetic counseling. So this is a study that was done. The group is primarily based, I think, at Penn, and trying to raise awareness among patients and primary care providers because they were recognizing that we weren't sending people off to get genetic testing enough. And so this was a study, and the patients automatically got a genetic counseling referral. So no one had to initiate it. So patient met criteria, they got the referral. But still, at the end of the day, look at the rates of testing. It's quite low. So patients have to follow through. So they got an automatic referral, but they didn't all get scheduled. And they got scheduled, but they didn't actually go to their appointment. They went to their appointment, they didn't actually get tested. So many steps along the way are failing in order to help identify. So we and many others have developed programs. So we have our program in young onset colorectal cancer, and we structure it sort of in this support. We called it support. Yeah, now it's called support. But really thinking about how do we best support our patients? So we have a dedicated young onset patient navigator and a program manager to sort of administer and help coordinate, and still obviously a big work in progress. But it includes the components of, social, who understands their challenges, who understands the employment related, the financial distress, integrative medicine and nutrition support, too busy to think about, what to eat and eat well, because you have to go to your treatment and you have to go to soccer practice, and you have to get your kids to school and do all those things. Supportive, and that requires supportive care. We are missing, and we used to have, but an incredible resource is a supportive, it was a pediatric nurse actually that we had who helped our cancer parents talk to their children about their cancer diagnosis, right? I mean, like, how do you talk to your kids, about your cancer diagnosis? Patient network, because, our younger people really like to engage with each other, right? Much more public. My kids know where all their friends are on Snapchat. I'm like, you really want everybody to know where you are at all times? Oncofertility. So we work with one of our oncofertility specialists, and then obviously, rehab and prehab, and then genetic testing and wound ostomy care. So those are kind of the components. And so through this program, one of the studies that was recent, and this was presented at ASCO this year, was, can we do better? Can we do better than 20% genetic testing? Because what are the issues, right? They have to get to the appointment. Well, they're busy. And so, all right, let's take the appointment out. We buy our airplane tickets online. We identify our seats online. We check in online. Nowadays, you can't even talk to anyone to check your bag in because you have to go to the kiosk and then you have to drop it off. And so the way we address this concept. So normally you see a person, a patient gets diagnosed. You see a provider who refers you to a genetic counselor. You see the genetic counselor. You get consented for testing. You get the testing. You come back to the genetic counselor, and then the provider gets information. What if we took out that initial step of having to see a genetic counselor and let them do it online? Let them do it electronically. And that's what was done here. So there was an education video that patients watched, and then they could decline testing, or they could then do consenting. It's an electronic consent. They could ask for a genetic counselor appointment, and then they would have not an appointment. They just get a blood draw, and the blood, and that would be for the sample collection. And so with this approach, 377 young onset colorectal cancer patients, 168 excluded because they already had testing or they couldn't be reached, et cetera. So 210 were electronically invited. So they got a message in my chart. And then of those, there were 160 patients who had interest, 40, and then 49 somehow ended up with testing again. Somehow they ended up with pre-referral testing. But amongst the 160,
and now
amongst the 160,
there's so much stress in your arm, if you see it, but about cancellation and
Christian, Sirwa, can you shut off your volume?
Glad to see we have people joining us virtually. So they're essentially, I think maybe if I click it, no, I got to go back. Let me go back. Shoot, previous precedente. Yeah. I thought I had the math worked out here, but it's like 96%. If you add up the 82 and the 14 and ultimately who got tested, which is 89, it ends up being like 90 some odd percent of the patients without ever seeing a genetic counselor. Like, that's pretty cool, right? And so I think it just took one of the barriers away, which was like, you have to go have an appointment, and you don't want to have that appointment. You don't want to have to go in. Like, you're not a sick person. Like, you want to go. And then the other people, those who didn't engage with that online platform. So of those 160 patients who should have gotten tested, 60 didn't engage with the online platform. So those who did really worked, and those who didn't, then they got referred to genetic counseling. So someone reached out to them. Now we have to kind of track them down. So maybe one solution to try to improve the status. I love this study. It's just an amazing study, right? It was run out of Canada, 55 centers, 900 patients who had completed chemotherapy for stage 3 colon cancer. And Chris Booth led the study out of Queens. And it was a 3-year, this would never happen in the US, like 3 years of a structured exercise program, although it became less intense. But the effect size for disease-free survival and overall survival far greater than any adjuvant chemotherapy. So the hazard ratio for the addition of oxaliplatin to 5-FU that makes oxaliplatin such a critical standard is 0.8. The hazard ratio here is 0.72, like way stronger effect. without giving any drugs, just by getting people to be active, and probably could help us reduce the incidence of early onset disease, and certainly would help us. Matt, how many times do we have patients who say, after treatment, like, okay, now what can I do to keep the cancer from coming back? Well, I'll tell you what you can do. And now we actually have evidence to help support that, like, level 1 evidence, but, it's convincing them to do it. And I think when I've been talking to patients, that it effectively is the health education arm, right? Because now we have a little bit more of a nudge, because when they come back for your surveillance visits, how come you haven't been exercising? And you can guilt them and all these things, but it's not the same as having a supervision. And I don't know how practical it is to do that. But anyway, I think it is so applicable to our young onset patients, because they are more active and they do have the opportunity to make an intervention that can improve their outcome. Also, so this is a study that was done in Germany. It was a qualitative study trying to look at, like, what are the needs? And so these are the themes that come through, and then all the different sub-themes, like, so the diagnosis, results in an impact on all the things we just talked about, right? The psychological well-being, physical well-being, the daily routine, their, future perspectives. I might not go for that promotion because I'm not sure I'm going to be alive. I might not make that investment because I'm not sure I'm going to be around to take advantage of it. And then there are all these experiences that they need, right? Rehab, stoma care, sports medicine, fertility counseling, et cetera. And so as the study was conducted, so these other themes emerged about what the expectations were in order to address these things. And it is improving the infrastructure, creating this wraparound, like making it easier for patients to interact with all these different people, to address all those issues, to have tailored counseling, to have, actually, one of the things that always comes up is wanting peer support, which is really interesting. And how many times do we have patients with LARS who said, I went on the LARS Facebook page and they said, and so, and I'm now doing hot tea enemas, stuff like that, right? So, and then, better communication channels, right? Not the traditional, I got to make a phone call, not a traditional, I got to wait for my appointment. They want it fast. They want it immediate. They want, actually, many of us who sort of deal, when you're dealing with your bank or the airline and you have a question and what you need answered, and they said, how would you like to chat? How would you like to chat with, with an agent? And it's not the agent, it's a chatbot. And then you do that, and it's frustrating because you have to ask 3 questions to get to that answer that you could have just asked some human being. But our younger generation is very accustomed to this and knows how to ask the questions right, and can get to the answer sooner and are more comfortable. And so I think we have to think about, how do we communicate better? And so to summarize, the overall incidence and mortality of a colorectal cancer is declining. And I think that's good news. And it's good news, and it tells us that we've been doing some things right. But the improvements are driven by patients who are over 60. There's a dramatic rise in those who are less than 50 with a strong birth cohort effect. 15 to 25% of young onset colorectal cancer patients are identified to have a pathogenic germline variant. And we also have, germline variants of unknown significance, and right, but the rest are sporadic. It's important for us to identify these people. So 100% of the patients who are under 50 should get that's sort of our approach. Is if you're under 50, you get genetic testing, referred at least. Young onset colorectal cancer is characterized by unique mutational characteristics, which may be driven by gut dysbiosis, and I think may hold the key for some future targets, how we can sort of intervene on these patients. And certainly, there's a lot of interest, particularly in the advanced disease, thinking about how we harness the microbiome. We have a study actually that we're doing now where it's called the Monarch study. Because of Morpheus, it's just that I'm just escaped. But it's the Monarch study, and we are altering the microbiome during neoadjuvant therapy to see if we can alter response. And it's something very simple because we're targeting BFRAG. And so how would we target BFRAG? It's an obvious drug that would be used, but it's very easy for patients. And so I think, it's kind of a really exciting time. And then young onset colorectal cancer patients have unique needs, and they're quite complicated, and they're multi-layered, and they need to be considered in their multidisciplinary diagnosis, treatment, and survivorship. And with that, thanks very much. Happy to take your question.
Thank you, Dr. Chang. That was a great talk. Anyone have any questions? Oops.
Don't forget to get your certificate of attendance.
Anyone have any questions in the audience?
Okay,
Where?
let's see. Here's one. This is from Maria Abu Kahil. What do you think are some of the low-lying fruit that we can implement in resource-limited settings to care for this population? Yeah, that's a great question. You know, we don't necessarily have to have a major infrastructure to make a difference, right? We can make a difference in every patient that we see. I think an important low-lying fruit is to always remember to have the discussion about fertility preservation, right? That should happen in our office. And what we're talking about and the genetic, you know, all that stuff about like sort of the online educational video, that's pretty cheap, right? You make the video and then you're done. But it's really trying to make up for the clinician who didn't do it, right? It's the clinician who didn't kind of have that conversation. Now, genetic counseling is a little bit different because the genetic counselors have a unique expertise, et cetera. But fertility preservation discussion is one, you know, it's a question of, you know, do you plan to have, you know, more children, or are you worried about fertility? Like, is this an important thing? And if they say yes, we need to make that referral. You know, at least that's something that, you know, that we can do. Now, following up on that referral, that's another question. You know, will the patient go, and, you know, all of those things. But I think that is, you know, kind of, you know, an important low-lying fruit. Another important low-lying fruit is really sort of just trying to spread the word. So the ASCRS is a big campaign this year on trying to promote awareness about young onset colorectal cancer. And so I think we're going to be hearing a lot more about it. But I think we need more of that, right? We need more of the beating the drum about how, because there's still people, and I think it's really helpful that we're seeing a lot of the media take this on as a topic of interest for them, because that's how we reach the population. But still, at the end of the day, so I learned a very interesting statistic. We think of 60 Minutes as being like this, like if you could get on 60 Minutes, that would be awesome. 60 Minutes gets 7 million viewers on a good night. Most of them are in their 60s and 50s. Joe Rogan has 25 million followers, and everyone is in the demographic that needs to hear about this. So we have to figure out, how do we get the influencers, you know, the people who access the people who need to hear. And, you know, that's not a low-lying fruit, but.
So when are you going on Joe Rogan?
Well, that might, you know, that's a very complicated question.
Okay, so if there are no more questions, I want to thank you for an excellent 2 days, excellent presentation. And we actually have a little
Oh my
plaque to
goodness.
give you. The Division of Colon and Rectal Surgery, Philip H. Gordon, visiting professor, presented to Dr. George Chang with our sincere appreciation for delivering the 7th annual lecture.
Thank you so much. Oh, we have to take a picture of this. Or maybe we'll just, this is better.
Thank
Thank you so much.